Hi, good afternoon, everyone. This is Dr. Vijai Bhola, and we are presenting today the return of polio as part of our WADEM infectious disease SIG. This is current as of August 2022. So one may ask, why do we decide to choose to present a topic such as polio? And quite simply, is that polio is a disease that we have come very close to eradicating. We thought we were essentially eradicating the disease in its entirety. But now we are seeing resurgences, and we really have to discuss why are some of these things happening, and especially what is relevance to this return of polio to disaster medicine. Outline, we will really focus on a polio epidemic in New York in 1916. Not that polio was specific to New York in any way, but really because it helps us to sort of capture the emotion and the significance and the impact on society that this disease can have, even in what was, even at that time, one of the more developed, one of the fairly higher socioeconomic income countries. We want to speak about polio vaccines, of course, and discuss the international eradication timelines, and then look at some of the resurgence issues we've seen. Then we'll discuss the two major vaccines, the inactivated and the oral polio vaccine, and discuss a little bit about the clinical features. So let's go back to the summer of 1916. During this time, there was a horrendous East Coast polio epidemic. There were almost 20,000 cases and 2,500 deaths. And if we look at this newspaper, this was in the middle of World War One, quite devastating. Yet the highlights are all polio. Epidemic strikes 617 babies, 35 dead of paralysis in 48 hours. New York City is terror stricken. Parents plan flight for 50,000 children. This sort of encapsulates the sort of raw fear and the disruption to society that was present at that time. Um, Towns outside New York City were actually posting guards to prevent the entry of city dwellers whom they feared would bring polio into their towns. Cats and dogs, strays were being killed because of a concern that they would spread the disease. At that time, FDR was Assistant Secretary of the Navy, and the future US President was vacationing with his family in Campobello Island, Maine. And some of his correspondence really encapsulates the fear, even among those well to do in society. He was afraid to bring his family home by train, saying that there was much infantile paralysis in Boston, Springfield, and Worcester, and that various villages were keeping motorists out. Uh, so much so that the next month, he used the Navy Secretary's official yacht to safely take his family to his mother's house in order to avoid the regular transportation routes, which they feared would become an issue because of polio at the time. And this was what it's all about. Multiple children, for example, seen here suffering diaphragmatic paralysis using the iron lung in a really crowded uh, theater at the time, being taken care of nurses. This was how significant this disease was. Years later, FDR himself was diagnosed with paralytic poliomyelitis. He felt ill, had a temperature, his legs gave way, and he was 39 years of age at the time. Now, in retrospect, there's been some discussion in the literature as to what his actual diagnosis may have been, but this is sort of not necessarily the point as much as just how significant his disease was within that time and in that context. Uh, After that, FDR is usually pictured seating in a seating position, as he is in this image in Pearl Harbor in 1944. And what we have to realize is that the impact of poliomyelitis was undeniable. This is a hospital for crippled children back in 1923. And this shows just how sad and devastating this disease is. It's not an exotic disease, as a matter of fact. It was considered a disease of industrialization at that time. And it's now some of the benefits of industrialization has brought us vaccines. And it is now vaccine presentable. However, it is exacerbated by war and instability, notably disasters in general. And another factor is the issue of vaccine hesitancy. which puts these gains against poliomyelitis at risk. Next, we want to look at a bit of the what has happened with the advent of these vaccines almost 30 years later. In 1955, Dr. Jonas Salk was credited with the production of the first poliovirus vaccine. He used to kill the poliovirus vaccine using the three strains of poliovirus that we knew to cause disease. 2 years later, the oral poliovirus vaccine arrived. This was credited to Dr. Sabin, who used an inactivated or attenuated strains of the vaccine, and this was given widely at that time, becoming commercially available in 1961. So again, the major differences between these two is that the oral poliovirus is weakened or attenuated and given by the oral route, whereas the inactivated is given by injection and it is of completely killed poliovirus. And one just needs to look at the international success stories of eradication. We just see the litany of countries almost sequentially declaring elimination of polio from North America, Western Pacific, Europe, Africa. And a major focal point was in 1989, the Global Polio Eradication Initiative. When that initiative was founded in 1989, polio was paralyzing 1,000 children daily, which is a really dreadful number. In just the first 2 decades of the 21st century, there was a 99% decrease in cases. So this shows just how much ability we have to control this disease. To the point that while poliovirus type 1 is the only one in existence present in Pakistan and Afghanistan at this time, the strains 1 and 2 have been eradicated. Resurgence of paralytic polio. 2002, cases seen in India, 2004 in Sudan, 2005 in Java, Indonesia. In 2022, cases have been resurgent in the US, first case since 2013. In the UK, the first case in 40 years. And in Ukraine, 19 cases seen very early related to the ongoing conflict there, and a suspension of vaccination campaigns. As we can see, war is definitely an enemy of vaccination campaigns, which requires some stability. And therefore, what suffers next are all those cases of preventable, vaccine preventable diseases. Let's look at more detail of the oral poliovirus vaccine. It is very cheap, it is safe, long lasting, and highly efficacious, 95% so. Because it is administered orally, it confers mucosal immunity and really helps to prevent transmission, onward transmission that is in an individual who has contracted polio via the oral route. It is very easy to administer, so very good for mass vaccination campaigns. In these, with the administration of this virus, the intestinal vaccine virus, which is weakened, circulates um, within the community and therefore can lead to passive immunity. So, to emphasize on this point, when this vaccine is given, this weakened virus can multiply within the GI tract and can be used essentially to confer passive immunity to contacts of that individual. So that can be very useful to get herd immunity, but also can be an issue if, for example, there are immunocompromised individuals within the family or contacts of that person. Disadvantages of the oral polio vaccine of these are very rare side effects. 2 to 4 events in 1 million births is the number of vaccine associated paralytic polio cases. Now, really, the vaccine itself can reacquire neurovirulence in a process that takes up to about 18 months, and especially in poorly vaccinated communities, this can circulate the contagious, newly reacquired neurovirulent vaccine virus can then spread within these communities, especially if these communities are poorly vaccinated. The inactivated polio virus, this is simply killed virus. So there is no risk of onward transmission, no risk of vaccine derived polio virus, and there's also no risk of vaccine associated paralytic polio. This vaccine is used exclusively in the US. It has an excellent protective response, 99% efficacious, which is quite high. One of the disadvantages, because it is given uh, I, IM and not via the oral route, is that there is not very good intestinal immunity. So WPW, wild polio virus, can still spread within the community. Note that if vaccinated, an individual is protected from contracting polio from any cause. However, if that person was then to come in contact with wild polio virus, then they still have the ability to spread that strain of wild polio virus within their community. So they won't necessarily stop the spread of polio via that route. The IPV is also more expensive, 5 times more than the oral poliovirus. So this is of extreme importance in lower income settings, especially. And because injection is required, sterile procedures, trained personnel, there are much more resources and it's much more resource intensive to administer this vaccine. There is another vaccine in the works. This is a novel OPV2 used under the emergency use listing of the WHO. Is highly efficacious, and because it is more genetically stable, there's a lower risk of vaccine derived polio. So, the crux of the eradication strategy is to get really widespread immunization with oral poliovirus. Um, and when this disease is under good control, essentially not being seen within the community, to then use the inactivated poliovirus, which can eliminate the risk of vaccine associated spread. Let's speak a bit about the clinical features of polio. So, only about 25% of cases are symptomatic, usually of just a flu like illness. Uh, 1 to 5% of cases may develop meningitis. And then 0.5 to 0.05% of cases will develop paralysis. So this is 1 in 200 to 1 in 2,000 risk of developing poliovirus uh, associated paralysis. And what's important here to note and to think of is that if there's a single case of paralysis, then that is just the tip of the iceberg. There are many other infections circulating in the community. And to compare this risk of paralysis, for example, with vaccine associated paralytic polio of the OPV vaccine, 2 to 4 events in 1 million births. So you really see a marked improvement even in the use of the OPV in terms of preventing poliovirus spread. So, in summary, polio is a really devastating disease spread by the fecal-oral spread, primarily affects children. And if there's just one case in the community, there are many cases that are probably just subclinical. The vaccines are safe and effective. And if we were to rehash both of those vaccines, the IPV is somewhat safer and more efficacious, but does not prevent transmission. The OPV is cheaper and easier to administer, but does have very, very small risks of vaccine associated paralytic polio and vaccine derived poliovirus. Eradication is still possible, and resurgence, however, is really related to issues such as disasters, war, decreased vaccination coverage, displacement of populations, or what we've been seeing now more and more is just a rise in anti vaccination sentiment, which really threatens the eradication of this disease as well as so many other vaccine preventable diseases. Just to take a look here, top left is a Time magazine photo showing vaccination campaigns being done in Pakistan within schools. Bottom is a headline from just this year discussing the comeback of polio in Ukraine as war halts vaccination campaigns. And to the right is a picture in 2007 from the WHO archives of a child with poliovirus. We want to thank you. Some of our references were WHO, CDC, GPEI, and Washington Post Archive.